Welcome to AETCM, the Emergency Medicine channel. Today we are going to talk about two different scenarios of patients coming to ER with complaints of foreign body ingestion. The first scenario, a 33-year-old female came to ER with complaints of sudden onset retrosternal chest pain and shortness of breath post incidental consumption of a juice which was made out of crushed nuts. On initial 10-second assessment, airway was patent. She was speaking in full sentences. Breathing wise, her respiratory rate was 30 per minute, saturation of 99% room air. Circulation wise, BP of 130/80 and a pulse rate of 106 per minute. GCS wise, E4 V5 M6. Exposure wise, she was afebrile and a GRBS of 92 milligram per deciliter. Patient was complaining of severe retrosternal pain. That's why we gave her at that point of time one PAN, one injection MSN and one injection paracetamol 1 gram IV stent. And we asked the patient to be kept NPO. Coming to sample history, 33-year-old female came to ER with complaints of consumption of a juice made out of crushed walnuts, following the consumption of which patient complained of severe retrosternal pain because she felt like she had swallowed a big chunk of the uncrushed walnut, and she was having foreign body sensation in the chest. Due to the pain, patient when she came, she was very much tachypneic and she was hyperventilating. She came in around 20 minutes after consumption of the juice. No complaints of hypersalivation, any regurgitation of food, any wheezing or any inability to swallow. She is not allergic to any known substance, not on any medications, no past history, and last meal was 20 minutes back. This was the first
case. We'll go to the second case.
Yes. Then coming to the second case, so, this is a 70-year-old female, sir. Patient actually patient was initially admitted in outside hospital with complaints of foreign body sensation in the throat 1 day after ingestion of fish, following which she had developed odynophagia. She initially admitted in outside hospital where emergency hypopharyngoscopy was done, and following which the fish bone was removed. Post procedure, patient developed surgical emphysema on the right side. They suspected esophageal injury, and that's why patient was referred to AIIMS for further management. On arrival, this patient airway was patent, breathing was 18 per minute, respiratory rate was 18 per minute, saturation of 98% room air, circulation was BP was 110/60, pulse rate of 86 per minute, full GCS was full, and exposure wise afebrile. At this point of time, we took a CBC-CRP point of care, which showed a total counts of 12,000 with hemoglobin of 11.8 and a CRP of 125.7. We had also ordered for chest X-ray for this patient.
Okay.
Coming to sample history, this patient was actually patient complains of foreign body sensation in the throat 1 day after ingestion of fish, following which patient developed odynophagia of throat. Went to outside hospital where she was posted for emergency hypopharyngoscopy under general anesthesia. During the procedure, severe edema and congestion was noted at the piriform area, and the procedure was abandoned at that time because scopy could not be passed. CT neck was done the next day, which showed a well-defined hyperdensity in the cervical esophagus from C5 to C7 level. Again, a hypopharyngoscopy was done under GA and fish bone was removed. Post that procedure, patient developed surgical emphysema on the right side. The next day, a repeat CT scan thorax was done, which showed irregularity at the D1 to D4 level with air shadow, suspecting esophageal injury. After which patient was referred here.
Okay, so we have two patients here. Now, one lady came in with an acute presentation and one came in with a probable complication of an esophageal foreign body. So, the first case, let's a 33-year-old lady, she was having some smoothie and she developed a sudden choking sensation. So, when all you will suspect an esophageal foreign body, what will be the clinical presentation of an esophageal foreign body? Airway we know, because airway obstruction, all those things, choking, stridor and all those things. So, which all conditions when the patient presents to the ED, you will suspect, okay, I am probably dealing with an esophageal foreign body. So, what will be the symptoms?
As a patient will present with sudden onset breathing difficulty, severe retrosternal chest pain, sudden onset dysphagia will be there.
Okay.
Then patient will have hypersalivation,
Okay.
regurgitation of food, then wheezing. Patient can develop wheezing, then odynophagia, painful swallowing could be there due to esophageal spasm. And if patient is having drooling and inability to swallow, it indicates esophageal obstruction.
So that will be the classical presentation that you will get. And when they present later on, as you said, they can have complications like again mediastinitis, subcutaneous emphysema. So whenever you are having a subcutaneous emphysema, there is some esophageal rent is there. So that is the next presentation. Next important thing, what are the probable different types of objects that commonly what we see in esophagus? Foreign bodies. In the esophagus, we are generally saying foreign bodies. So what are the probable foreign bodies? 1, 2, 3, 4. You can just elaborate.
So usually
in children, we are not going to discuss. Children, we will keep it separate. Children, you have coins, button batteries, the super strong magnets and all those things. That is a totally a different entity. I am telling about an adult patient, common foreign bodies that what we will see.
Usually it is after consumption of any fish or meat, foreign bones or fish bones could be stuck. Other than that, sometimes if any tablets...
okay, most commonly we can classify this way, sharp and blunt objects. That is the easiest way. So sharp objects and blunt objects. So the whether we are going to get a sharp like a fish bone being a sharp object, a pin. We had a student who had a pin injection recently. So pin and versus a blunt object. Anything can be a blunt object. So that's the most common thing that you see in an adult. Again, most commonly these products can be a part of your food. Maybe food bolus can get impacted also. So that is a situation. Now that are the different types of foreign bodies that you are anticipating. Now let's see where all the impaction can happen as per the esophagus, in the esophagus.
Sir, esophagus actually physiologically narrowing. 3 places are there. First is the upper esophageal sphincter, most common site of impaction. Second is at the level where the aortic arch crosses the esophagus, and the third is the diaphragmatic hiatus.
That's it. Otherwise, you can call it as the lower esophageal junction or the sphincter. So these are the 3 common areas where there is normally narrowing, where there can be food impaction or any foreign body can get impacted. Now let's see what are the common site of impaction in an adult patient and then children. In children, it's more commonly in the upper esophageal sphincter. That is the most common one. And in adult, it is more in the lower esophageal. So that is the usual presentation. Now, when you have suspected such a patient coming to the ED, airway, we are secured. Remember that there is no compromise in the airway. How will you proceed further? What are the investigation, radiological investigation that you will ask for? Most important one, what all things you needed. You have CT, you can do MRI, but what is the most common investigation that we can do?
So if patient has ingested any object which is radio opaque, then we can ask for a chest X-ray. Initially we have to give the patient NPO. If pain is there, we have to give pain management. After that, if it is an opaque and radio opaque substance, we can ask for an X-ray. If it is not, we can go for a CT, but also like we can go for endoscopy. Like for in consideration of CT, endoscopy should not be delayed.
Okay, fine. So again, as you said, radio opaque, radiolucent object. Usually food boluses X-ray is not required. But otherwise, any other foreign body that you are suspecting, you can ask for which X-ray, chest X-ray, AP view you can ask for. And in children, when you have battery injection and all, you always should ask for a lateral view also. Because whether it's a single battery or it's a multiple battery, only by doing a lateral view, we'll be able to appreciate that. So children will keep it aside. So X-ray is the most common investigation. And again, CT as and when it is required, when you are suspecting a complication or whether you are unable to see anything and you don't have an access for an endoscopy immediately, that is the time that you can consider maybe for a CT. And how will you know that this is probably at this level? So you said regarding something very specific in that CT. So that corresponds to what level? You said it was between C5 and C7. So C5 and C7 is what? C6 is the level of the lower or upper esophageal sphincter? Lower or upper? which is the upper esophageal sphincter. So it is the upper esophageal sphincter, that level that impaction has happened. You just see that it is the between C5 and C7. That was the CT image, no? So C6 corresponds to that level, and little bit lower down is the crossing of the aorta, everything is happening, and lower down you have the lower esophageal sphincter. And so it has actually happened in the in the upper esophageal sphincter only, but in adult we commonly see it in the lower esophageal, but she has in the upper esophageal sphincter. So that is what the CT image, CT report has suggested us. So now let's see, the option is here to remove the foreign body, that is very clear. Now esophageal foreign body, you have to ask for an endoscopy. Suppose you don't have an endoscopy facility, or you have an endoscopy facility, when you will ask your gastrophysician or surgeon, whoever is doing an endoscopy, this patient require an urgent endoscopy. So 1, 2, 3, come immediately and do an endoscopy. And you can come, you can see couple of your patient and you can come and do endoscopy. So when you want him to run down and come and do an endoscopy, that is immediate.
So esophageal foreign body usually should be removed within 24 hours. That can be divided as emergent endoscopy or urgent endoscopy. Emergent endoscopy has to be done within 2 hours, latest by 12 hours. This is in scenarios where there is complete esophageal obstruction, where there is drooling of saliva. Then if there is disc batteries in the esophagus, or we are suspecting any sharp pointed objects in the esophagus.
Sharp pointed object in the esophagus, yes. They should come down and immediately do an endoscopy and it should be removed.
Then in urgent endoscopy, that should be within 24 hours. Any foreign body which is any foreign body in the esophagus has to be removed by 24 hours, because otherwise it will lead to complications like any food impaction, anything that is there.
Suppose you imagine that this has gone to the duodenum. Imagine it has gone to the duodenum. What will be the foreign body? So how will you go ahead further?
Duodenal,
if it is a small foreign body, it depends upon the length and the width of the foreign body. So if it is more than
2.5
width, you have to immediately endoscopy. More than 6 centimeter length, again immediate endoscopy. And foreign body, sharp object, immediately you have to remove it. And suppose anything below this, you can try for conservative management, but still the foreign body has not gone. You are doing a weekly follow-up, and after like 2 to 3 weeks it is still impacted, you need to go for an endoscopy. But usually you have endoscopy easily available, so nobody waits for such a long time. So if it is easily removable, you can remove. Now what are the techniques? Sometimes you will not be able to remove the foreign body completely. So what are the options available for while doing your endoscopy technique? Just simple things. One thing, you can push the object into the stomach. Maybe whether it is in the lower esophageal sphincter or in the upper esophageal sphincter where there is narrowing, you can push it and you can crush it and you can remove, or you can use something like an snaring things that they will do for ERCP, for the removal of stone. Something like that, you can retrieve that foreign body, or sometimes you can put some pressure and you can try to push it down also. There are different methods, but our idea is to basically, you have to remember that immediate endoscopy, whenever you see a sharp object inside the esophagus, immediately it should be removed by doing an endoscopy. That is the priority number 1. And any drugs can help. Any drugs. Look, there has been some evidences where you can give 1 to 2 mg of IV glucagon, but the problem with glucagon is vomiting. So it can cause, again the patient is having a problem, so vomiting. So if you want to try glucagon, you have to give a good antiemetic like ondansetron. Then maybe you can try glucagon, but there are some anecdotal evidences where they can give carbonated drinks. So carbonated drinks can push forward, but these are all not of having any evidences. Like giving a calcium channel blocker, maybe for achalasia cardia, the sphincter will relax and all, and benzodiazepine. These are all been tried, but have not been found to have any evidences for the esophageal foreign body. So that is the one set of the initial part. Now the second patient, whatever we had, the second patient we discussed, she had gone into a complication probably. So probably she had an subcutaneous emphysema. It is very clear there was some rent perforation has happened. Perforation would have sealed off by itself, or you might need a surgical intervention during that time. And what will be the possible potential complication? Esophageal perforation, mediastinitis, sepsis, lung abscess, and all those. It's the list prolongs like that. So how we can manage that patient?
So that patient, when patient already suspected of esophageal perforation, then we have to do another endoscopy to look for exactly where the site is and to whether to repair it surgically or not. if there is tear, like in transmural tear, usually like Boerhaave syndrome, where there is transmural tear, usually requires surgical correction. But if it is like not transmural, it's like 1 to 2 layers of the mucosa only involved, then conservatively it can be managed, sir. Patient can be orally, and patient can be
keeping them NPO
till the edema subsides, till it heals, and nasogastric tube can be put for patients feeding till.
Okay. So how is the second patient doing right now?
So she was put on a nasojejunal tube, and she was started on feeds, observed, she was tolerating. Then they discharged her on the nasojejunal tube and asked to review after 1 month. Sir.
1 month, okay. So she should be possibly, by the time some antibiotics also they would have prescribed, and she should be coming back. Okay. And first lady, what was done?
Sir, actually, she was taken up for OGD scopy. A CT thorax was done, sir. CT thorax showed just below the level of carina, there was a focal dilatation of the esophagus with air foci. Query, it was like trapped foreign body. There was no extraluminal air foci, no pleural effusion, normal lung parenchyma. So she was immediately taken for OGD scopy. The scope was passed into the esophagus, and there was a walnut in the mid esophagus. So they attempted to move it with a Roth net, but they could not. So could not negotiate through the upper esophageal sphincter. So they pushed the foreign body inside the stomach and crushed it in the stomach. Then the subsequent scopy was done, which showed mild edematous mucosa only. Otherwise, normal stomach.
So it sounds simple, but it can be one of the deadliest emergency, and airway compromise, again, one of the very problem that we can handle, we need to handle is the airway management. So esophageal injuries, just remember whom you need to have an urgent endoscopy, when you will suspect, and again in children it's totally a different ball game. They will not know whether what has happened. We don't know any history. Maybe in old age people like Alzheimer's and all, we don't know, we will not be able to get any proper history. But this is an adult group of patients where they are telling that they had a foreign body injection, they have something feeling. Don't neglect it. Get at least food boluses usually, but maybe an elective endoscopy might be required for those group of patients, and radiopay can be picked up easily by an X-ray. And if required, like button battery only, you need a lateral view. Otherwise, an APU will be more than enough. Fine. Anything else that you want to add on?
No.
Fine. Thank you.